This week's Ask Dr. Durie is an important question, which is, does the type of myeloma impact the choice of treatment? Well, for the normal typing of myeloma, IgG, IgA, kappa or lambda bench-Jones myeloma, non-secretory myeloma, or even some of the rarer types of myeloma do not really impact the choice of treatment because the outcomes are really pretty much the same, except for possibly a recent article which indicated that the outcomes for non-secretory myeloma might be a little bit better versus the other types. But the main things which do impact the choice of treatment for myeloma patients are the types of genetic testing. And so the most broadly available testing which we use is the FISH testing, the fluorescent in situ hybridization, the FISH test, which is a bone marrow test in which we determine if some of the poorer prognostic chromosome abnormalities are present or not. And those abnormalities are what we call the translocation 414, the abnormality where there's a 17p minus, where part of the 17 chromosome is missing, or there's a problem with chromosome number 1, for example. With those types of chromosome abnormalities, we've learned that we need to be more cautious about our choice in treatment. And in particular, we have evidence that using a proteasome inhibitor could be advantageous, particularly using Velcade and more recently carfilzomib. And we also have some good recent news. A recent report in the February issue of the Blood Journal indicated that pomalidomide could be useful, particularly in patients with 17p minus and the 414 abnormality. More sophisticated genetic testing using gene expression profiling, what we call GEP, or even full genome sequencing can be used to assess risk. And in this situation, there can be a high risk or a low risk classification, which can be used as a basis for using more or less aggressive therapy. Unfortunately, right now, we don't know exactly how best to treat patients with high-risk myeloma, except to consider a new clinical trial in which a more aggressive approach could be considered. For example, to include some of the newer drugs such as elotuzumab, or perhaps a HiDAC inhibitor, or even one of the newer monoclonal antibodies. In addition, there is a small subgroup of patients who might have a specific mutation which shows up on sequencing. The best example of this is the BRAF mutation, for which we do have a specific inhibitor. And so use of this inhibitor can be helpful in the 4% of patients who might have this abnormality to have some shorter-term benefit. And so the genetic abnormalities are the key things that might lead to a different choice in treatment, and more we will be relying on those kinds of tests to help refine treatment choices.